you enter your details there in an online form, and you should be emailed a CPD certificate immediately. If for whatever reason it doesn't work, we have your details, and if you do need them, if you get audited or something, just reach out. We're able to sort it out. And I think that's it from me. So yeah, take it away, Sarah. Thanks for joining us.
Hi, everyone. Thanks very much for having me. So I decided to talk a little bit about hepatitis C because I think it's an interesting subject, and not, as Jeremy says, we're starting to see more and more of it. But I think it's an interesting subject, not only because of the science, but also because of its story. And so so this presentation is a little bit science and a little bit story, and I hope you'll find it interesting. So in 2017, the WHO released its first ever global hepatitis report. And the global prevalence of hepatitis C infection is about 1%. And currently there are about 71 million people living with hepatitis C. In 2015, there were 1.75 million new infections globally. And that's about 500,000 more than the number of people cured of hepatitis C and dying of hepatitis C put together. There are high rates of infection in the Eastern Mediterranean related to unsafe medical injections, and in Europe, and that's related mostly to intravenous drug use. Compared to hepatitis B, as a result of this diversity, the infected population is more heterogeneous. About 50% of people with hepatitis C are unaware that they have it. So half people don't know that they've been infected at all. And the prevalence of anti-hepatitis C antibodies in HIV and infected individuals in MSM is about 6%. So just a mention about Egypt's special case. So there's an interesting, what might be called excess incidence in Egypt related to the use of unsterile injection equipment. And it's often blamed on the mass campaigns for the treatment of schistosomiasis using an intravenous formulation of something called potassium antimony tartarate, which sounds very alchemical. And that was used up until about the 80s. But it doesn't seem to account for all of the cases. Egypt has about a 15% prevalence of hepatitis C, and that's the highest in the world. And so traditional practices involving multiple injections may be responsible as well. Rural Egyptians get about 4.5 injections a year for various things. And IV catheterization at home for saline and glucose by health barbers. So the health barbers are becoming less frequent, but for a long time they were health barbers and clinic attendants who used to reuse intravenous catheters for the delivery of saline and glucose in people's homes. So in South Africa, again, it's the estimated prevalence is about 1% of the total population, and that amounts to about 400,000 people who are chronic carriers of hepatitis C. So just some basics about the virus. Hepatitis C is an RNA virus, and it has no RNA polymerase proofreading capacity. In addition to that, it produces about 1 trillion variants every single day. And the RNA codes for a 3,000 amino acid polyprotein. So that's a large polyprotein, and there are lots and lots of viruses being produced every day. And so there's a high chance of creating a genetically diverse viral population. Hepatitis C has 11 genotypes and more than 80 subtypes. And these genotypes are distributed in an uneven fashion around the world. South African genotypes have been assessed in blood donors and in patients. Genotype 1 occurs in about 31% of people in South Africa. Genotype 2 is in about 2%, genotype 3 in about 14%, 4 in about 14%, and 5 in about 35%. And you can see what's an unusual phenomenon that occurs, which is that genotype 5, which is this gray area here, is almost exclusively a Southern African phenomenon. There's a small number of people in East Africa who also have genotype 5, but genotype 5 seems to be a fairly local phenomenon. And the variability in genotype has had implications for a long time for therapy because of the differential response to the different combinations of antiviral agents. So this is a slightly scary slide. So over the last 15 years, we've seen a reduction in mortality from 3 big infectious diseases. So TB, HIV, and malaria. And, I would be cautious to say that we are winning the battle against those three diseases, but, perhaps we are being less soundly routed than we have been in the past. But the reverse is occurring for people who are infected with hepatitis. So in 2015, there were 1.34 million deaths, and that's about the same number of deaths as non-HIV associated TB, more than malaria, and more than HIV from people who die from HIV-infected individuals who die from things other than TB. And the problem is that these numbers may still remain an underestimate, because the deaths that are recorded due to liver failure or cirrhosis or hepatocellular carcinoma may not indicate the original cause of the pathology. So these patients may have their liver failure, cirrhosis, or hepatocellular carcinoma as a result of hepatitis C, but that information is not recorded in the death certificate. So the majority of patients die from complications related to hepatitis B and hepatitis C infection, those hepatitis deaths. There is a proportion of the hepatitis B related deaths that are also related to hepatitis D superinfection. The lifetime risk of cirrhosis, Hep C, and hepatocellular carcinoma and liver failure in a patient infected with hepatitis B is between 15 and 40%. For hepatitis C, the risk of cirrhosis within 20 years is between 15 and 30%, and you have a 1 to 4% yearly risk of developing hepatocellular carcinoma. Most deaths occur in people who are over the age of 30, about 93%. And in sub-Saharan Africa, the median age of death from hepatocellular carcinoma is only 38. So this is a nice little slide for transmission of all viral hepatitis infections that I've stolen from Dartmouth College. But obviously what we're interested in is the hepatitis C, really. So transmission of hepatitis C is either parenteral, much less commonly sexual, and rarely vertical from mother to child. So just when taking a history to assess the risk of parenteral infection, you need to include asking questions about the use of IV drugs, acquiring tattoos or piercings, receiving any transfusions. Obviously, these days, we hope that our blood products are safe, but receiving transfusions about 30 years ago is still a risk. Scarification, needle stick injuries, and to some degree, sharing household items like toothbrushes and razors. So that may pose a very, very small risk, but if you are living with a hepatitis C infected person and you happen to use their razor, there is potentially a small risk. Sexual history needs to include questions about partner numbers, about traumatic or bloody intercourse, transactional intercourse, and men having sex with men, as well as HIV status. And HIV status is also important in vertical transmission. In an unmanaged delivery, the risk of transmission from an HIV positive, hepatitis C positive mother to the child can be as high as 17%. But of all those possibilities for transmission, hepatitis C is most likely to be transmitted through intravenous drug use. So it sounds like a small number of people when you say that between 0.2 and 0.5 of the world's population injects drugs. But when you look at the global seroprevalence of hepatitis C in people who inject drugs, being about 51%, that amounts to 7.2 million infections in 2014. The seroprevalence of hepatitis C in the US reaches 98.7% in people who've been injecting drugs for more than 30 years. And 60% of acute infections in the US are due to injection drug use. And again, most commonly, injection drug use is the most commonly reported route for transmission in 33% of acute infections and 83% of the chronic infections. And there are some things that may be affecting the likelihood of transmission, that now drugs are allowing higher injection frequency, so people are putting needles in their arms more often during the day, a decrease in needle and syringe programs, and low levels of substitution therapy. So just to mention a couple of interesting case reports, there were 2 hepatitis C and HIV outbreaks that were described in Europe, in Athens and in Bucharest between 2011 and 2013. And that's the sort of time where The financial crisis was affecting those countries, and it was associated with financial restrictions in harm reduction programs. It affected mostly young males who were unemployed and were homeless and had no medical insurance. At that time, Greece had an unemployment rate of 58% in people who were under the age of 25, and in Romania, it was 26% in that same group. And the reason that I'm mentioning this is that there is a correlation, or there is a comparison that we can draw with our own country. In the first quarter of 2021, unemployment overall in South Africa reached 32.6%, and youth unemployment reached 63%. And we can potentially expect those numbers to rise related to an ongoing COVID outbreak. So the estimated number of people who inject drugs in South Africa is about 75,000. Doesn't sound like an awful lot, but I think we can see that the scene is set perhaps for increasing numbers. So this was a study that was done in South Africa in 7 sites in South Africa, 7 cities in South Africa. The study recruited 3,439 individuals from high-risk key populations, and those populations were sex workers, MSM, and people who inject or use drugs. And they administered a socio-demographic questionnaire, and they took some bloods. And the bloods included hepatitis B surface antigen, Hep C antibody, viral load, genotype, and HIV antibody. And the interesting thing that you can see is that, where's my pointer? The interesting thing that you can see is that hepatitis C seropositivity was much higher in this group who inject drugs compared to hepatitis B and HIV. And obviously hepatitis B seropositivity is affected by childhood vaccination. And it's mentioned in the study that individuals who were young enough to have been vaccinated as children had a lower rate of hepatitis B infection. So what's the natural history of hepatitis C? So 20% of people, which is not very many, will clear their hepatitis C infection, and 80% will progress. Of those that progress, about 20% will develop cirrhosis. So the sources, range between saying 15 to 30%, but about 20% will develop cirrhosis. There's a 1 to 5% annual risk of developing hepatocellular carcinoma and a 3 to 6% annual risk of hepatic decompensation. And if you do happen to decompensate, your risk of dying in the following year is between 15 and 20%. So what are the things that affect progression of disease? So age, the disease progresses about 300 times faster in people in their 60s compared to people in their 20s. Rates of fibrosis in males are 10 times higher than in females. If you drink more than 50 grams of alcohol per day, you may progress faster. And 50 grams of alcohol equates to about 3 drinks. So that's about 450 mils of wine, which is 12% alcohol, about a little bit over a liter of beer at 5%, and 140 mils of spirits at about 40%. And it's associated with a high likelihood of worsening fibrosis. HIV infection is also related to faster progression. It increases hepatitis C RNA. It decreases the response to interferons, which may not be a factor these days, really. It increases progression to fibrosis, and you're 2 to 3 times more likely to develop cirrhosis. And then as far as hepatitis B infection is concerned, patients who are Hep B surface antigen positive are at risk of reactivating their hepatitis B during Hep C treatment and need to be carefully monitored. And then, as with all chronic infections or chronic diseases in general, host genetics are likely to play a role. So this is just a pretty picture of replication, and it's a fairly standard drawing that we see in terms of viral replication. There's just a couple of interesting things to mention in terms of transmission. The virions exist as lipoviro particles because they associate with LDL and VLDL in the host. So they are pleomorphic and heterogeneous, so they look different to your immune system. Virions, it's random how they associate, and they look different to to your immune system, and that may be one mechanism by which they evade neutralization. Another mechanism may be that they engage in cell-to-cell transmission in the liver. Although the entry mechanisms into the cell remain the same, the mechanisms overlap in many circumstances, but it may be one way in which hepatitis C avoids neutralization. So there are some guidelines in terms of who to test, and the new recommendation in the US from the AASLD, the American Association for the Study of Liver Disease, and IDSA, is that everybody needs to be tested for hepatitis C once in their lives. So why have they recommended that? So it's because the risk-based strategy, so asking all those questions about risk exposures, sexual partners, and how many tattoos you've got, and how many intravenous drugs you use, fails to identify more than 50% of hepatitis C infections. And obviously, these activities may be, risk activities may be stigmatized. People may not want to volunteer, or they may not answer honestly when you ask them about their drug use. So they may not report them. So the recommendation is for a one-time routine opt-out strategy for testing for hepatitis C. So everybody older than the age of 18 years, and then in women, again, with each pregnancy. For people who are younger than the age of 18, you would assess their risk activities. So those include, obviously, intravenous drug use, intranasal drug use, which may be associated with other drug use, and MSM. And then risk exposures. So these are things that may have happened once or twice and not necessarily ongoing. People who have long-term hemodialysis ever in their lives. If they've had any percutaneous or intravenous medical exposures in an unregulated setting. So if you, I don't know, are backpacking through Africa and end up in a barbershop with a needle in your arm. Healthcare workers who've had needle sticks or sharps exposure or mucosal exposure to hepatitis C positive blood. Children who are born to hepatitis C positive mothers. And then people who have had transfusions or transplants, or anyone who's ever been in prison. And then the other conditions that they're mentioning are HIV infection, anyone who's likely to start PrEP, anyone with chronic liver disease or hepatitis, which I would have thought was a no-brainer, and then any solid organ donors or recipients, which again, I hope if I'm getting a solid organ, someone's going to test it for Hep C. And then periodic retesting for that group who have those risk exposures or risk activities. But there's the recommendation is kind of loose. It basically is that the clinician decides based on the likelihood of infection or reinfection how often to test. But in people who inject drugs, MSM having unprotected sex, and MSM using PrEP, the recommendation is for annual testing. So how do you test? So you test with an antibody test, followed by a reflex Hep C RNA PCR if it's positive. And a positive antibody test obviously means acute or chronic infection. It might indicate past infection, and sometimes, very rarely, a false positive might occur. So the Hep C PCR can be a confirmatory test. False positives might occur in areas of low prevalence. And if a false positive is suspected, a repeat antibody test with a different assay should be used, because it's unlikely that both of those antibody tests are going to return a false positive result. If you've been exposed to hepatitis C in the last 6 months, but your antibody test is negative, you would do a Hep C RNA PCR and repeat the antibody in 6 months. If you are immunocompromised and you may not be making Hep C antibodies, you would do a PCR. Also, if you're suspecting reinfection after spontaneous viral clearance or treatment, obviously you expect the Hep C antibody to remain positive, so it's not a diagnostic test anymore, and you would do a Hep C PCR. Obviously now everyone's an antibody expert in the era of COVID. Everyone wants to test their antibodies and know how long their antibodies last and so on. So it's important to counsel people who are Hep C positive but RNA negative that the antibodies are not protective against reinfection. They are a marker of past infection, but they don't protect you from future infection. Genotyping, not necessary now really with the pan-genotypic treatment regimens, but you would consider it if the patient was serotic or treatment experienced. And then in addition to the Hep C test, everybody who's got Hep C needs to be tested for HIV and hepatitis B. So what are the testing options? So the current testing methodology in sub-Saharan Africa uses lab-based testing methodology. On this list, you can see the only test that is a point of care test is the OraQuick rapid antibody test. These are the FDA approved Hep C antibody tests. So if you want to test somebody for Hep C in sub-Saharan Africa, you need to stick a needle in their vein. You need to make sure that the cold chain is maintained, that the specimen arrives at a lab within 48 hours, and then your lab has the ability to centrifuge the specimen that they've received. But there are two point of care tests available. The one is the OraQuick, as mentioned, which says it can be used on oral fluid, venipuncture blood, fingerstick blood, plasma, and serum. Although if you try and look at the package insert and you try and find some directions on how to use it exactly, that's only really described for whole blood. But there are studies showing that it has acceptable sensitivity and specificity on oral fluid. It's just that I couldn't find something that says you can definitely use it. And then the SD Bio line, which can also be used in plasma, serum, or whole blood. So there was a study which was nested in the study I mentioned earlier, looking at key populations. It was from researchers at the Center for Vaccines and Immunology at the NICD. And it looked at how well the OraQuick performed on blood and oral samples, and how well dried blood spots worked for standard lab tests, testing Hep C antibody and viral load. So the study was done in that high-risk group of individuals, sex workers, MSM, people who use drugs, from Cape Town, Durban, Pietermaritzburg, Mthatha, PE, Joburg, and Tshwane. And it performed really quite well. So the point of care test on either whole blood or oral fluid showed an overall sensitivity of 98.5%, a specificity of 98.2%, and an accuracy of 98%. And then the dried blood spots showed a sensitivity of 96, specificity 97, accuracy 96. And there was a strong correlation between the viral load measurements for the dried blood spot samples and for the plasma samples. So also just to have a quick look at the breakdown of individuals. So the vast majority of the individuals who were Hep C positive were people who used drugs again. So point of care tests and simplified blood collection methodology and techniques involving a dried blood spot may well allow us to upscale Hep C testing in South Africa. And certainly, I think oral sampling is more acceptable in general to a lot of people than needles. All right, so if you make the diagnosis of hepatitis C in your patient, you would then need to counsel them about how to make sure that they don't spread it to somebody else. So in the house, you would suggest that they don't share potentially contaminated items. So as mentioned, things like toothbrushes, dental equipment, shaving equipment, there may be some small risk attached to sharing those items. To cover bleeding wounds and to clean anything that's been contaminated with a bleach solution, and wear gloves while doing it. Since everybody's wiping their houses down with bleach solution at the moment, that's probably eliminating that route of transmission anyway. If you are a Hep C positive and you're having sex, if you are HIV positive, if you have other STIs, or if you have multiple partners, you need to use barrier protection. And the suggestion in the guideline is that if you don't have any of those factors, it's probably okay not to. I'm a little nervous about that recommendation, but that's the recommendation. And then if you happen to be a Hep C positive person and you are feeling altruistic and would like to help your fellow man, you should not donate blood. And if you want to donate other tissues, such as your organs after you die, then you need to make sure that you speak to somebody about the feasibility of doing that. And then in terms of people who inject drugs and counseling after you've made the diagnosis of hepatitis C. So you need to counsel them about harm reduction related to illicit drug use. And obviously the solution is to try and make sure that they stop using drugs. But that's not always the simplest thing to do. And if they are going to continue to inject drugs, they need to be counseled to avoid reusing or sharing needles, water, cotton, drug preparation equipment. They need to use new sterile syringes and filters and disinfected cookers, clean the injection site with a new alcohol swab, and then dispose of the syringes and needles after one use in a safe puncture-proof container, which sounds lovely. It sounds all very fantastic to prevent transmission of hepatitis C. And maybe it's possible if you are an individual living somewhere in California where you may have access to a safe injection site and somebody providing you with a needle that comes in a package and a cuff and a chair on which to sit while you inject your drug. It may not be so feasible in situations where, and I think this is the vast majority, where people are injecting with their friends on the street with a needle that everybody is using, and they're cooking on unsterile equipment. The top left picture comes from the Sowetan, and it's a picture of drug users in Johannesburg. The top right and bottom left are drug users in Kenya, and then the picture on the bottom right is just from the internet. But I think this is, you know, it's all very well to make those lovely recommendations, but you have to be in a situation where those things are feasible. So the question we need to ask ourselves is, why does South Africa need to care about hepatitis C? So these are the mid-year stats from 2020. And in 2020, we had almost 80,000 people dying of AIDS-related deaths. We have 22% of women between the ages of 15 and 49, or almost 23% who are infected with HIV. We have 7.8 million people living with HIV in the country at the moment. And we have 1% of our population, which is about 400,000 people, who are infected with hepatitis C. So are we going to be wasting our time and our money and our energy treating this population of 400,000 people when we have an uncontrolled epidemic in the country? But the landscape, I think we need to realize, is changing. And this is where the story starts. And so is there a parallel of some sort between the US opioid epidemic and the South African situation? So what happened in the US? So this is an article. Well, it's not really an article. It's barely even a letter. It's like 10 lines long. And it was published in 1980 in the NEJM. And it was a letter that basically said, we looked at some files of 39, almost 40,000 hospitalized patients. 11,882 of those patients got one narcotic, and only 4 people became addicted. And 4 of those people had no history of addiction. We don't know about other people who became addicted who had a history of addiction. And basically, they're saying that it's absolutely fine to treat patients with narcotics because treating patients with narcotics does not result in addiction. So the problems with this letter obviously are that it's minute. The references don't seem to reference, if you can try and track them down, they don't really seem to add any support to the statement. So there were 12,000 almost patients who got at least one narcotic preparation. So it's only one dose of something. We don't know how many of them only got one dose of something. We don't know what the dose was. We don't know what the drug was. 2 tablets of Stopain is not the same as 50 milligrams of pethidine. They were all in hospital taking supervised medication. There's no description of what constitutes a major addiction or a minor addiction. How did they decide it wasn't really that bad in 3 of the 4 patients? But this letter was subsequently cited over 900 times when it came to supporting the prescription of narcotics in the US. And some of those citations called it an extensive study because it had 40,000 patients in it. So in 1995, Purdue Pharmacy introduced and aggressively marketed a long-acting version of oxycodone, which was a slow-release version over 12 hours. And it claimed that OxyContin was safer in terms of addiction than other opioids for this reason, because it was a slow-release agent. During the year that it was released, the company increased its sales force by 600 salespeople. They sponsored 40 conferences in vacation destinations to which they invited 5,000 delegates, all expenses paid. The company spent $207 million on its marketing campaign, and it really, really worked. In 1996, 316,000 OxyContin scripts were written. In 2002, 7.2 million were written. And in that year, the company made $1.5 billion from OxyContin alone. By 2015, Purdue Pharma had made $35 billion from the sale of OxyContin. So OxyContin here is made in strengths of 10 to 160 milligrams. And because it was a controlled release formulation, it was feasible to make it in higher doses. It seems like it may have been less effective and not actually a 12-hour slow release medication, because a lot of doctors were prescribing it as an 8-hourly medication. And also, if you happen to crush the tablet, you can overcome the slow release mechanism, and you can get a powerful morphine-like high from snorting or injecting the drug. And this is something that Purdue Pharma was aware of prior to the application for approval to the FDA. And court documents in subsequent lawsuits have revealed that the company's sales representatives used the words like street value and crush and snort in 117 notes recording their visits to doctors and other medical professionals between 1997 and 1999. So the sales force knew that these drugs were being used as drugs of abuse. So why were people suddenly prescribing? Obviously, the marketing campaign was one thing, but there must have been another reason for the prescription of these medications. So there was a organization known as the Joint Commission. And the Joint Commission was originally called the Joint Commission on Accreditation of Healthcare Organizations. And it was a nonprofit organization that set standards and accredited hospitals and medical centers. And in 2000, in 2001, it made a standard that said pain should be assessed in all patients. So the American Pain Society had developed this concept that pain was the fifth vital sign and it needed management. And so when the Joint Commission, which accredited hospitals, said you have to assess your patient's pain levels, and if you didn't assess your patient's pain levels, you were given requirements for improvement if they failed to meet that standard. Obviously, now hospitals and healthcare centers are feeling an obligation and pressure to assess pain and make sure that pain is not present in their patients. The standard itself made no mention of treating the pain with drugs or opioids specifically, but it did print a book in 2000 that stated that there was no evidence that addiction is a significant issue when persons are given opioids for pain control. And it called doctors' concerns about addictions, side effects, inaccurate and exaggerated. And there was this term opioid phobia that was coined. And interestingly enough, that little book that was printed and distributed at CMEs was sponsored by Purdue Pharma. But OxyContin wasn't the only opioid being prescribed with more frequency. Between 1997 and 2002, other preparations of oxycodone scripts, they increased overall by 402%, hydromorphone scripts by 96%, fentanyl by 226%, and morphine prescriptions by more than 73%. And it seems like doctors jumped on the bandwagon as well. So pain clinics popped up all over the US, which were called pill mills, where in one example that's given, you could get 3 opioids, a muscle relaxant, and an anxiolytic, a prescription for 3 months after a 15-minute interview during which you described your painful condition. So what happened ultimately? So in 2007, the Purdue Pharma, 3 of their executives pleaded guilty in federal court to criminal charges that they had misread regulators and doctors and patients about the drug's risk of addiction and its potential to be abused. And at that stage in 2007, the fine was $600 million. And 3 executives from Purdue Pharma, including its president and its lawyer, pleaded guilty to misbranding, and they agreed to pay a total of $34 million in fines. So in October last year, a subsequent settlement was released with the Department of Justice in the US for $8.3 billion because of defrauding the US and violating anti-kickback laws. So there's a breakdown of what that actually comes to, and an additional $10 billion has been allocated to settle other claims. The Sackler family, which owned Purdue Pharma, will also have to pay $225 million. But since they withdrew from the company between $10 and $13 billion, $225 million seems like a drop in the ocean. And if my maths is correct, which it may well not be, that's only about 1.7% of their profits. So the company was aware that their original formulation of OxyContin could be abused. If you crushed it, you could snort it, you could boil it up, and you could inject it. And so they developed a formulation that could not be crushed as easily and became sticky and so on when you tried to boil it, and you couldn't draw it up into a syringe. So the changes in the OxyContin abuse from year one, from a year before to 3 years after the OxyContin reformulation were calculated, and the abuse of OxyContin just related to the change in formulation decreased by 48% in National Poison Center surveillance systems, by 32% in the National Drug Treatment System, and by 27% among individuals who were prescribed OxyContin in claims databases from medical insurance. Doctor shopping for OxyContin decreased by 50%, and overdose fatalities reported to the manufacturer decreased by 65%. So it seemed to work quite well. However, the damage had been done, and the opioid abuse epidemic had begun. And the problem is that OxyContin is actually quite expensive. And heroin, it turns out, is quite a lot cheaper. So retail prices for heroin per kilogram and per gram, here we've got in the United Kingdom, costs you $68 per gram. You can get a pretty good deal in Greece. You only pay $26 a gram. Portugal as well is a good place to go if you're shopping for cheap heroin, and Belgium as well. Don't want to go to Finland. Finland's very expensive for heroin. So in the US, these are the retail prices for heroin. So the average in 2016 was $152 per gram. And if you want really pure stuff, it's $491 per gram. And the street value of an 80 milligram tablet of oxycodone is $80, which is $1 per milligram. Again, my maths, but I think it's correct. And $1,000 per gram. So suddenly, OxyContin becomes much less available, but it doesn't really matter because heroin is much, much cheaper. So what does the South African epidemic look like? And is this going to be a problem for us as well? Well, it is partly a problem for us as well because of where the heroin comes from. So in recent years, Afghanistan has accounted for 80% of the global heroin production. And the northern route, the land-based trafficking route through the Balkan states to Europe, has been affected by conflict in the Balkans and by improved policing. The southern route includes passage through and past South Africa. So opium production spiked in Afghanistan at 6,400 tons in 2014, and 62% of that turned into heroin. In South Africa, the price of heroin and cocaine fell by more than 75% between 1992 and 2001. And that's probably related to the opening of borders and participating in the global economy. And obviously that makes those drugs more available to poorer people and to younger populations. In addition to that, we've got quite good air and sea connections. We've got porous borders. We've got undermanned ports, and we have lots of secondary airports. And we know that if you're a high profile criminal or a warlord, or somebody fleeing the authorities, you can fly in and out of those airports without much control. And in addition to that, we now have just under 2/3 of our young population unemployed, and that those unemployment figures are likely to rise. So at the moment, what we have in Chatsworth is a sugars problem. We have an unga problem in Cape Town. We have a nyope, wunga or wunga problem in Johannesburg. And the base drug of all these various compounds is heroin, mixed with marijuana and any other number of agents. And it's pretty cheap. So what do we have available in South Africa in terms of managing the opioid epidemic? So we do have some needle and syringe exchange programs, but they're not extensive. There are some opioid substitution maintenance therapy programs, but again, they're not extensive. We certainly don't have many supervised drug consumption rooms. And in terms of overdose prevention from peer-based naloxone distribution, so what you want to do is you want to give the naloxone to somebody else who knows that you're using or is using with you, so that if you happen to overdose, they can give you the naloxone. So these people are obviously not asking for heroin to be legalized. They're asking for dacha to be legalized. But I think the principle applies that drug users are not actually criminals, and we need to figure out ways to make their habits, although ultimately the solution is for them to become clean and to stop using drugs. But if they continue to use drugs, we need to make it as safe as possible. All right, so back to the US epidemic. So I think we need to be a little bit careful that we are going to start seeing a lot more hepatitis C than we have in previous years. So this is a graph showing the changing epidemic in the US. So this is data from California. And in 2007, you can obviously see that the larger number of people in their 50s, they are baby boomers. They have either acquired their hepatitis C infection through iatrogenic exposures from blood transfusion or from intravenous drug use. And then in 2015, you start to see a second peak. So now the peak has moved on. Now that's the 60-year-olds, that baby boomer peak has moved on a little bit. And now we're starting to see a peak driven by younger persons who inject drugs. And that peak is continuing to grow. So the CDC estimated that there were 41,000 new infections in 2016, but not all states are collecting data, so that may be an underestimate. And the upper limit of the estimation was about 140,000 new infections in 2016. And it may be that the worst consequence of the opioid epidemic is not necessarily hepatitis C, but in fact the overdose deaths. So this is a graph showing overdose deaths over time. And it shows a rise in organ donations from people who died from overdose deaths. So with 13.4% of the most recent organ transplant from donors who died of overdose. In 2017, 13%, up from 1% in 2000. The unfortunate thing is that a lot of these individuals are actually otherwise healthy. And they have healthy functional organs. So is it possible to use those organs? So there is recent data to suggest that if you give a hepatitis C positive kidney to a Hep C negative person and then treat the recipient, you can prevent them from becoming ill with hepatitis C. But what about hearts and lungs? So historically, those organs have been discarded, but transplant surgeons are starting to use those organs and again treating the recipient. But obviously preventing the infection from preventing transmission is much preferable because you avoid the possibility of relapse of infection with complicated resistance profiles and then drug interactions with Hep C treatment to consider as well. So this was a study that was looking at, this is a recent study looking at hepatitis C transplant. So they looked at 16 donors who were hepatitis C infected, who were younger than 70 years old, who had no hepatitis B, HIV, or HTLV 1 or 2. And there were 25 recipients of organs from those individuals. The recipients were Hep C uninfected and had no previous liver disease. And so the drugs that they were given were an hepatitis C entry inhibitor and a combination of 2 DAAs. And my pronunciation of these drugs is absolutely terrible. I'm starting to feel like people just, grab a bunch of Scrabble tiles, throw them up in the air, and then name a drug after what lands on the floor. So I must apologize that my pronunciation of these drug names is terrible, and I will avoid them if possible. So they were given a combination of the hepatitis C entry inhibitor and the DAAs 6 to 12 hours before surgery, and then every day for 7 days after surgery. The organs that were transplanted were lungs, hearts, kidneys, and kidney pancreases, and only the lungs received any kind of pre-treatment before they were transplanted. And the tests that were done were a hepatitis C RNA daily from day 1 to 14, weekly from week 2 to 12, and then once at week 24. And it worked really very well. So 100% of the patients achieved undetectable HCV RNA at 12 weeks after transplantation. And 7 of those 25 recipients achieved SVR at 6 weeks. There were 3 participants who had detectable HIV RNA post-treatment. 2 achieved SVR at 12 weeks and 1 at 6 weeks. And there were no safety concerns noted, so there were only a few transient elevations of ALT and CK reported. So it really appears that this is an effective method for being able to use those organs from individuals who unfortunately overdose. All right, so looking at treatment. So the treatment timeline for hepatitis C, I mean, the landscape for treating hepatitis C has changed dramatically over the last few years. Sorry, I apologize for my barking dog. So in 1989, hepatitis C was identified. And in 1990, in the US, hepatitis C was tested in donor blood. It only really became effective in about 1992 when blood banks started using sufficiently sensitive tests in all blood banks in the US. In 1997, the first interferon was approved, followed by ribavirin in 1998. And there were subsequently different formulations of interferon, and the pegylated interferons were introduced in 2001 and 2002. The first directly acting antiviral agents were approved in 2011, and that's boceprevir and tenofovir. And they are both no longer available, and they have been superseded by other agents. They were approved only for genotype 1, given in combination with pegylated interferon and ribavirin. So it was a complicated regimen, but again, it was a shorter regimen than had been previously used, but still quite complicated and only for one genotype. In 2013, simpliprevir and sofosbuvir in combination with peg interferon and ribavirin for genotype 1, and then sofosbuvir, ribavirin, and interferon for genotypes 1 through 4 were approved. In 2014, the first daily combination without interferon or ribavirin was approved for genotype 1, and this combination is still available and is still available for treatment. Also in 2014, a combination of ombotasvir, paritprevir, and ribavirin and dasabuvir in a 2-tablet formulation was brought to market for genotype 1. And in 2015, the same regimen was then made available for the treatment of genotype 4 as the first regimen without interferon. 2016, now we're starting to see short courses, all oral, single tablet for multiple genotypes, and various different combinations being produced of various different DAAs. And then in 2019, the generics became available of sofosbuvir and velpatasvir, and ledipasvir and sofosbuvir became available. And one of my hepatologist colleagues said that permission was granted to the Indian generic companies to make them, but the truth is they were going to make them anyway. So this is just some examples of the various drugs that are available. Epclusa is sofosbuvir and velpatasvir. It'll cost you $75,000 for a course in the US. Vosevi will cost you $75,600. That's the addition of one extra drug, and that'll cost you $600. Zepatier will cost you $55,000, and Harvoni, which is not here, which is the ledipasvir and sofosbuvir, will cost you $94,000 in the US. In South Africa, however, you will get generics, and if you get standard first-line treatment, it'll cost you between 14,000 and 21,000 rand. Obviously, there are going to be a large number of people for whom 14,000 or 21,000 rand is an impossibility. I mean, I think a lot of us are sitting here thinking, geez, 14,000 rand to cure your hepatitis C, that sounds like a bargain. But I think for a lot of people, that's still out of their reach. If you want to buy Maviret, that in South Africa, there is no generic, and it will still cost you 400,000 rand for a course. So this is just a summary of the directly acting antivirals and options for treatment. And with the vast majority of these combinations, cure for hepatitis C is actually excellent. So who do you treat now? Well, you treat pretty much everyone, except those who have a limited life expectancy, who are not expected, that limited life expectancy is not expected to be remediated by liver transplant or hepatitis C treatment or any other directed treatment. Sustained virological response is pretty much the same as cure as far as we can tell. SVR in observational studies also leads to less liver inflammation, less progression to liver fibrosis and hepatocellular carcinoma, lower liver-related mortality and fewer transplants being required, and fewer symptoms and lower mortality from extrahepatic manifestations as well. And when to treat? Well, earlier is better. So the presence of fibrosis is required as an assessment before treatment. It's a robust prognostic indicator. Patients who have been treated and have fibrosis, who have achieved SVR but have fibrosis, still need to be monitored for ongoing development of hepatocellular carcinoma, esophageal varices, and hepatic function, and they may need longer treatment as well. So the diagnostic standard for assessment of fibrosis is a liver biopsy, but that can be difficult. So the alternatives are using routine tests and calculators to assess the likelihood of fibrosis, or direct biomarkers or liver elastography. So hepatitis, and just to remember that hepatitis C RNA does not correlate with disease stage. So the direct markers are products of extracellular matrix from activated hepatic stellate cells, and there are a number of them, and I'm sure a lot of us are looking at these thinking, I've never asked for that test. And there will be many areas where those tests are not available. Just as I mentioned, if you are looking for somebody to do a fibro scan on your patient who has hepatitis C, it is available at the liver practice at Donald Gordon. Okay, so just a reminder about the APRI score and the FIB4 score. So these are, if your direct serum biomarkers or liver elastography or a liver biopsy for that matter are not available, then the FIB4 score and the APRI scores can offer some guidance in terms of fibrosis, but they are not sufficient to rule out fibrosis. All right, so these are the combinations that are available and some ways in which to use them. Not really going to go through them because obviously all these things are in the guidelines and everybody can read, so I'm not really going to discuss them. And then recommended options in terms of the genotypes, and you can see that there are sofosbuvir and velpatasvir. You can see there is pretty much available for all the genotypes and for both no cirrhosis and compensated cirrhosis. So now we're talking about simplified treatment. So treatment for hepatitis C has become very boring. So for simplified treatment for patients with no cirrhosis, you would do an FBC, an LFT, a UNE, a Hep C viral load, HIV, Hep B, and prior to initiation of therapy, you would do a pregnancy test to exclude pregnancy. You would do a cirrhosis assessment as discussed. And there are some patients who are not eligible for simplified treatment. So obviously people who've had hepatitis C before, those who have cirrhosis. So there is a simplified treatment algorithm for people who do have cirrhosis. If they are HIV or Hep B positive, if they are currently pregnant, if they have hepatocellular carcinoma or prior liver transplantation. So simplified treatment, there are 2 first-line regimens that can be either given for 8 weeks or 12 weeks. And then the minimal monitoring idea is that you do a Hep C viral load and an LFT at 12 weeks. If you have achieved SVR, then the patient can be discharged. If you assess this patient as having a high risk of reinfection, you would do a hepatitis C PCR annually, or if you do a blood test and it happens to be that the patient has a deranged LFT, you would repeat the Hep C investigations. If there's no SVR achieved, you would recommend transfer to a specialist. I'm not sure that anybody other than a specialist is giving treatment in this country. And you would monitor for progression until retreatment is available under the specialist. So the WHO goals are for elimination of hepatitis by 2013. I think many of these elimination goals have been interrupted by the COVID epidemic, but obviously one must aim high to try and achieve these things. Right, thank you very much. That's all I have to say.
Thank you so much. Excuse me, sorry. Really nice overview of a complicated topic, and we got to learn all about where to get the cheapest drugs, which is awesome on a Monday, especially.
Yeah.
But, thank you.
By the end of the week, sometimes you need that.
Exactly. Good to know on a Monday. Who knows what the week will hold. So I'm going to go through, if you don't mind, some of the questions which have come up. One was about a vaccine for Hep C. So they're asking why we don't have one. I mean, as I understand it, the subtypes are quite difficult to bind together in a single vaccine, or I don't know. Do you have any insights?
So I didn't get around to including the vaccine story. There are not a lot of articles about vaccines, but I think one of the things is that you know, most of our vaccines generate antibodies, and we know that even a naturally generated antibody against hepatitis C is not effective. So it's quite difficult to create. My understanding is that it's quite difficult to create a vaccine when you're not totally sure what you're aiming for. There are people who are working on it, but my understanding is that it's related to the immunology, not necessarily just to the genotype.
Yeah, and I suppose probably a little bit less urgent with such good treatment at the moment. I'm sure to set that back a little bit as well. And then there's a question saying, you know, about hepatitis B and HIV are obviously among the factors that influence progression of Hep C. And then does the converse hold? So does Hep C impact the natural progression of HIV or Hep B?
I'm not sure that it impacts the natural of HIV, but I think, you know, if you have multiple liver pathologies, multiple viral pathologies in the liver, they will interact with each other. I think the effect of hepatitis of HIV on Hep B and Hep C is the immunological component, you know, the immunological factors related to HIV that allows progression.
Yeah, agreed. And then someone was messaging me now about the South African incidence. So, I mean, it's a notifiable condition, but presumably it's not notified very often, like most notifiable conditions are not. Do we have data showing an increased incidence yet in South Africa, or has that not yet been done?
No, so it seems still that the wisdom is that it's up to 1%, that it's still less than 1%. But I think, you know, that's related to people thinking about it and people testing for it. And I certainly think that, you know, HIV is much more on the radar than Hep C, and we don't automatically test people for Hep C when we test for HIV. You know, we test the drug users who come into hospital. But yeah, I think the incidence is probably on the increase.
Yeah, I agree. Certainly, I mean, anecdotally, it's what most of us, I think, have seen in the last, say, 10 years or so, is an increase in the amount. It was almost unheard of before, whereas now it's not at all unheard of, as you say, especially in the high-risk people, those with endocarditis from IV drug use and etc.
Yeah.
That's fantastic. Thank you so much. And I think we can leave it there, but that's really, really great. We appreciate it. Yeah, thanks.